Today, class, we will be discussing respiratory complications for nursing 411 complex nursing situations. So, your patient is Mr. Robert Carone. He is a 57-year-old male. He was admitted to the medical unit this morning with shortness of breath, with mild chest pain, which increases with deep breaths, and mild fever. His condition deteriorated and his symptoms increased in severity, which required intubation. His last set of vital signs post intubation was his temperature 38.2 Celsius, his heart rate was elevated at 120, blood pressure 110/60, and his SpO2 was 95%. He's on an FiO2 at 50%. So the respiratory tech will provide the vent settings for you. He's currently sedated with fentanyl and midazolam. He also received roconium during his intubation. He had a nasal pharyngeal swab for COVID-19, which the results are still pending. He is a full code. His past medical history includes hypertension, BPH, and type 2 diabetes. His wife is at home and the physician is calling her right now to update her on the patient's condition and transfer to the ICU. So what are we doing today? Our learning outcomes are as follows. We're going to understand the infectious disease transmission factors and required modifications to practice that should be considered when selecting appropriate PPE equipment to adhere to principles of infection control and prevention. We're going to identify the need for and perform endotracheal suctioning for the intubated patient to maintain a patent airway. We will adhere to practice interventions for a patient in a prone position to prevent deterioration of the patient's status. Continuing with our learning outcomes, we will conduct a nursing assessment for an intubated patient to determine the next steps in his care. We'll communicate essential information to the healthcare team in a critical care situation to determine the most appropriate plan of care. And finally, we will evaluate potential causes of ventilator alarms for the intubated patient to prevent adverse outcomes. Okay, so here are some areas I need you to reflect on while you're involved in the case study. Consider, what are the key considerations for the prevention of ventilator-associated pneumonia? What are the key considerations? What would be key considerations when caring for a patient in a prone position? So here now, you can stop the lesson and you can read up on ventilator-associated pneumonia and patients being nursed in a prone position. 3 other reflective questions are, what are some challenges you anticipate when caring for an intubated patient in a prone position? How will you modify care to address these challenges? How will you determine the appropriate care to delegate to other health providers? Specifically, consider what you would delegate to the unlicensed assistive personnel or the LPN. What safety considerations should be observed when caring for a ventilated patient? Although neurological assessment provides important information, effects of both sedation and paralytic agents make results very difficult to interpret. So if your patient is sedated, you will have a very hard time assessing your neurological status of your patient. Interpretations of neurological signs must consider level of sedation. Coma and motor skills should be evaluated as appropriate using validated scales such as your GCS or your 4 and MRCP. We will discuss all of these scales in this course. Although respiratory assessment is a key assessment, more information is needed. The nurse should obtain a comprehensive overview of the patient's current clinical conditions. So yes, you are right. Upon admission to the ICU, the nurse needs to gather baseline data. How does she do this? How will she do this? A systematic approach must be used for a head-to-toe approach. Each system should include clinical observation and examination. If you would recall in your health assessment class, the first thing you must do is observe, followed by assessment, and in assessment comes your objective assessments, those that are validated through an instrument and what the nurse assesses physically on the patient. As this patient is in isolation, the nurse should be organized and complete all necessary assessment and task at once. This is called bundling your nursing skills. This response is not correct, and this is not a typical finding, especially immediately following intubation due to respiratory failure. COVID-19 significantly impacts the respiratory system. This is also not correct. This is not a typical finding, especially immediately following intubation due to respiratory failure. Stridor occurs when there is a narrowing of the upper airway, typically found in patients with CROP, foreign body obstruction, or a tumor in the upper airway. There are some key features for you to consider. Key features of the respiratory assessment of a patient with COVID-19 include decreased air entry and diffuse crackles. As heard on the video, as COVID-19 progresses, air sacs, which is the alveoli, becomes filled with fluid leaking from small capillary blood vessels in the lung. This can lead to ARDS, requiring ventilator support. So let's look at uncompensated respiratory alkalosis. Uncompensated respiratory alkalosis results from alveoli's hyperventilation, and hypocapnia, which means increased elimination of PCO2, less than 35 millimeters of mercury, and the pH will be greater than 7.45. Remember, your pH is 7.35 to 7.45. Anything greater than 7.45 indicates alkalosis. This occurs in any condition that increases the respiratory rate, hyperventilation, or death, causing the lungs to blow off CO2, eliminating the acids, causing an increase in pH or alkalosis. So let's look at compensated respiratory acidosis. In this case, in compensated respiratory acidosis, compensation occurs when the body's ability to maintain a normal pH occurs due to other systems' contributions. When the primary cause is a respiratory acidosis, that means there's excess retention, you're retaining CO2, the bicarbonate should be greater than 26 if compensating and attempting to normalize the pH. When we look at uncompensated respiratory acidosis with moderate hypoxemia, that's low blood oxygen in the blood, these ABGs indicate an alveoli hypoventilation, meaning the lungs are unable to rid the body of enough CO2 to maintain a normal pH balance. This is occurring due to decreased respirations or inadequate gas exchange. The body has compensatory mechanism. Remember, the body's always trying to maintain homeostasis to restore a normal pH through chemical buffers, respiratory, and renal influence. When we reach to the renal system, we're going to talk about the renal influence in balancing the pH. Respiratory acidosis can result from respiratory depression, such as drugs that suppress the respiratory centers, such as hypnotics and opioids and sedatives. If you can recall, our patient did receive sedatives and opioids. As the patient respiratory rate of 30 breaths per minute, he's breathing above the ventilator. This does require intervention, but it is not the priority at this time. This is not a priority action. The oxygen saturation reflects the body's ability to carry oxygen to the tissue. That's what the O2 sats tell us. The human body requires and regulates a very precise balance of oxygen in the blood. This is important to monitor as if it can fluctuate depending on how many health conditions are involved. Respiratory acidosis usually occurs as a result of hypoventilation, thus, prioritizing the patient's SpO2 is not the priority at this time. So, this is correct. You need to assess the FiO2. While administering and titrating the FiO2, it is important to determine the underlying cause of the respiratory imbalance in order to select an appropriate intervention. What is the cause of this patient's respiratory imbalance? Respiratory acidosis is caused by a lack of respiratory effort or pulmonary problems such as a chest wall trauma, airway obstructions, or conditions causing decreased surface area such as pulmonary edema or respiratory infection. We can ascertain that our patient does have a respiratory infection. No, this is not the correct choice. So Mike is right. The respiratory therapist is right. Again, this is not the correct choice. What we need to remember is pressure alarms equal obstructions. You do not want to turn it off, you need to check it. High pressure alarms are the result of an obstruction in the circuit caused by one, secretions, kinks in the tubing, patients biting on the tube, or anxiety. The nurse looks at the patient first, not the machine, and asks whether the data correlates with the patient's appearance. So if your patient is lying there, he's not anxious looking, he's not coughing or coughing against the tubing, then we need to check to see if there's any kink in the tubing. If anything in the system is intact, or if everything in the system is intact, inline suctioning is warranted.
Would you consider proning this patient?
At this time, ABG is not important. So why not ABG? Why not arterial blood gases? Although arterial blood gases is important to monitor the effectiveness of ventilation, yes, we do that. It alone will not, or it alone, sorry, will not improve oxygenation. The ABG was also recently collected. Do you recall us looking at our ABGs a few minutes ago? The R and the S bar should include recommendations to improve the patient's oxygenation. By now, you would have already looked up Google pruning, so you know about the nursing action related to pruning. To avoid artifacts during pruning, chest electrodes should be placed on the posterior chest wall, not the anterior. It is recommended that reverse Trendelenburg should be used to diminish eye pressure and prevent microaspirations. Key considerations are: position your electrodes on the posterior chest wall, label and secure your IB lines, protect pressure areas, protect eyes, ears, and genitals, and eliminate tugging from catheters and devices. So when you are looking, if a question comes up and it asks, what are your nursing intervention? Nursing interventions are actions that does not require a physician's order, but it is beneficial to the patient's care. Such as, one, you don't need a doctor to tell you to put the electrodes on the posterior wall. That's best practices. Label and secure your IV lines, because you want to make sure that the patient's not laying on the IV lines. You want to protect your pressure areas. You want to protect your eyes, ears, genitals, and eliminate tugging. Make sure your lines are free. Remember, pain assessment in critically ill patients is a challenge due to mechanical ventilations. A lot of time your patients are sedated and paralyzed. Severe illness, administration of sedatives and analgesics, or decreased level of consciousness makes this very challenging. This limits the ability to obtain the patient's self-report. Normally, you would ask the patient, are you having any pain? which is considered the gold standard. So you will have to come up with other ways of assessing your patient's pain level. The Train of 4 test is not one to be used at this time. It is used to assess the level of neuromuscular blockade using peripheral nerve stimulator and is not indicated for assessing pain. So now your patient is sedated. How do you assess pain? Patients who cannot communicate, the physiologic and the behavioral dimensions of pain should be considered. Various assessment tools, such as your critical care observation tool, use observable behaviors such as facial grimacing or restlessness. That will be your behavioral dimension to assess pain, sometimes supplemented by physiological indicators such as vital signs, heart rate elevated, increased respiratory rate. So finally, some critical thinking questions for you to reflect on. Do you believe families should be permitted visitation for intubated patients during COVID-19? I can tell you that a lot of hospitals across America, what they're doing is they're doing FaceTime, and the patient's family members would call in at a certain time, and they are allowed to do FaceTime. The patient may not be aware that this is happening because the patient is sedated, obviously, but at least the family members have some sort of closure. How will you assess pain in the intubated patient? We just talked about some of the ways to do that in the previous slides. Do you believe it is important to communicate with intubated and unresponsive patients? I hope your answer is yes. And if yes, why? The nurse in the emergency room department does not routinely provide care to the ventilated patients. Now, what happens is you can intubate a patient in the emergency room, and eventually the patient will be transferred. So it's not that the nurse will not see this happening or will not be involved, but it's not routinely done. Do you think the emergency room nurses should maintain competency in ventilator care? Yeah, because remember, if a patient needs to be intubated, their Glasgow Coma scale is less than 8, they need to be intubated. It does not mean that the patient needs to be transferred to the ICU and then intubated. It means that you need to intubate right then and there in the emergency room. How can the nurse maintain this competency? So if you were a nurse right now and you were working in the emergency room, how would you maintain your competency in dealing with ventilators? When when contacting the patient's family to give an update on the patient's conditions, there are a significant language barrier. That means the patient speaks Creole or Spanish or French or whatever. How should the nurse ensure information is understood by the family? How you would make sure, how would you make sure that a family who speaks another language understands what is happening with his or her loved one?